Hi friends, I'm Dr. Jeevram. Today I will discuss about childhood diarrhea, gastroenteritis. Seasonality, sporadic cases all over the year, peak of morbidity and mortality in summer and early fall, summer diarrhea, small peak during winter, acute respiratory tract infections associated with secondary diarrhea. The infectious cycle, the natural history of the disease, etiology, it is multifactorial, primary infection of GIT, wild causes, rotavirus 70%, enteroviruses, adenoviruses, hepatitis A and E viruses, bacterial causes, E. coli, Shigella, Salmonella, S. aureus and others, protozoal causes, Giardia, Entamoeba histolytica, B. coli. Secondary diarrhea is a complication of other diseases, viral diseases, measles, rubella, mumps, chickenpox, bacterial infections, acute respiratory tract infections, tonsillitis. Source of infection, reservoir, human, main source cases and carriers, animals in some infection, Salmonella, Balantidium coli, external, with stool of infected person plus vomitus. Period of communicability, as long as the organism is excreted in stool, usually 2 to 3 weeks. Mode of transmission, ingestion infection, contaminated water with human excreta or sewage, contaminated milk and milk products, contaminated food, handling, flies, dust or polluted water, contaminated bottles, teats and utensils used to prepare baby formulas in feeding. Incubation period from few hours up to 2 to 4 days according to causative agent. Pathogenesis, invasive diarrhea invades intestinal mucosa, Salmonella, enterohemorrhagic E. coli, enteroinvasive E. coli. Secretory diarrhea, enterotoxins stimulate secretions of epithelium cells, enterotoxigenic E. coli, Vibrio cholera, Staphylococcus aureus. In osmotic diarrhea, disaccharides enzymes decreased, causes hydrolysis of disaccharides into monosaccharides in lumen, which causes osmotic diarrhea. Others, increase motility, interference with absorption, malabsorption. Clinical picture of childhood diarrhea. In mild cases, fever, no or mild, diarrhea, mild, less than 5 times per day, usually no vomiting, dehydration, no or insignificant, systematic manifestation, no or mild, self-limited within few days, moderate in severe cases, sudden onset with fever, irritability or apathy, anorexia, abdominal cramps and distension, diarrhea, frequent up to 20 or more, with blood and pus, vomiting, usually appears later. Clinical types of diarrhea: acute watery diarrhea, acute onset of frequent loose or watery stools without visible blood, lasts for less than 14 days. Chronic diarrhea, lasts for greater than 14 days with remission and exacerbation. Persistent diarrhea, acute diarrhea that lasts for 14 days or more without remission and exacerbation. Dysentery, diarrhea with visible blood in the stool. Complications of diarrhea: dehydration, which is the major cause of mortality, nutritional deficiency, recurrent diarrhea predisposed to protein, energy malnutrition, vicious circle, increased susceptibility to systematic infection, especially acute respiratory tract infection, cardiovascular, nervous and urinary complications. Laboratory diagnosis: acute disease is managed without waiting for investigation. Lab diagnosis is of practical value for persistent or recurrent cases only. Microscopic examination of stools, stool culture to isolate causative bacteria, serological testing for viral infection, especially rotavirus. Prevention of childhood diarrhea. General measures: sanitary clean environment, safe water supply, milk and food sanitation, sanitary waste disposal and fly control, health education of mothers, breastfeeding and proper weaning, food and milk sanitation, use of ORS, health promotion, adequate nutrition, prevention and control of systematic infection, general and specific measures, rotavirus vaccines and measles vaccine. A clinical syndrome affects GIT, has different etiologies, viruses, bacteria, etc., characterized by diarrhea, usually associated with vomiting and fever. Control measures for cases: aim, early case finding and proper treatment; mild cases, outpatient care and continued treatment at home; severe cases, hospitalization. Components of treatment: rehydration therapy, diet therapy, symptomatic treatment, supplementary treatment, treatment of underlying disease, chemotherapy. Case assessment: history plus clinical examination. How to assess a case of diarrhea for dehydration. History: personal, name, age, sex, address. Diarrhea: duration, frequency, consistency, blood. Vomiting: duration, frequency, color. Urination: last time urine passed. Thirst: other complaint, fever, cough, skin rash, ear problems. Feeding and fluid intake, time, type, amount. Previous treatment during this episode, ORS, drugs, vaccination history. Weight to assess degree of dehydration, amount of fluid required for initial rehydration. 1 gram weight loss is equal to 1 ml water loss. Temperature: fever may be due to infectious diarrhea, associated infection, otitis media, pneumonia. Dehydration: disappear after rehydration. Examination to detect presence and severity of dehydration. Associated conditions: undernutrition, otitis media, pneumonia. Complication: ileal paralysis. Assessment of dehydration: mild degree of dehydration, weight loss less than 5%. General condition: well alert, pulse slightly increased, blood pressure normal, respiratory rate slightly increased, urine output normal. Moderate degree of dehydration, weight loss 5 to 9%. General condition: restless, thirsty, irritable, weakly increased pulse, blood pressure decreased, respiratory rate increased, urine output decreased. Severe degree of dehydration, weight loss 10% or more. General condition: drowsy, cold, extremities lethargic, pulse sometime increased, impalpable, blood pressure decreased, may be unrecordable, respiratory rate deep, rapid, urine output markedly decreased. Assessment of dehydration: mild degree of dehydration, eyes normal, tears present, anterior fontanelle normal, mouth plus tongue normal, skin pinch goes back quickly. Treatment according to Plan A. Moderate degree of dehydration, sunken eyes, tears absent, anterior fontanelle depressed, mouth plus tongue dry, skin pinch goes back slowly. Treatment according to Plan B. Severe degree of dehydration: very sunken, dry eyes, tears absent, anterior fontanelle very depressed, very dry felt mouth plus tongue, skin pinch goes back very slowly. Treatment according to Plan C. Treatment Plan A. Treatment of diarrhea at home to prevent dehydration and malnutrition. Food plus fluids plus follow-up. Food: continue feeding. In breastfed child, continue breastfeeding. In non-breastfed child, give usual milk. If child is 6 months or older, give starchy food mixed with vegetables, meat or fish. Add 1 to 2 teaspoonfuls of vegetable oil to each serving. Fresh fruit juice or mashed banana. How often and how much food? During diarrhea, at least 6 meals per day. Frequent small feedings are tolerated better than less frequent large ones. After stoppage of diarrhea, Extra meal for 2 weeks. In malnourished child, extra meals is given until the child regains his normal weight for height. Fluids: ORS, oral rehydration solution, rice water, soup, orange juice, yogurt. Unsuitable fluids: fluids which can cause osmotic diarrhea and hypernatremia, soft drinks, sweetened fruit drinks, sweetened tea, fluids with stimulant, diuretic or purgative effects, coffee. Some medicinal teas or infusions. How much fluid to give? General rule: give as much fluid as the child or adult wants until diarrhea stops. As a guide, after each loose stool, give children aged less than 2 years 50 to 100 ml of fluid. Children aged 2 to 10 years 100 to 200 ml. Older children and adults as much fluid as they want. Follow up for the following symptoms: repeated vomiting, persistence of fever, persistence of diarrhea, severe thirst, poor eating or drinking, blood in the stool, or the child does not get better in 3 days. Definition of diarrhea: passage of 3 or more loose or watery stools in 24 hours, a single loose or watery stool containing blood. Diarrhea is an increase in stool frequency or liquidity that is considered abnormal by the mother. ORS: packets each of 5.5 gram dissolved in 200 ml water. WH formula: each packet contains sodium chloride 0.7 gram. For replacement: sodium bicarbonate 0.5 gram for correct acidosis, potassium chloride 0.3 gram for correct hypokalemia, glucose 4 gram for nutrient. How to give ORS solution? Teach a family member how to prepare and give ORS solution. Use a clean spoon or cup to give ORS infants and young children. Feeding bottles should not be used. For babies, use a dropper or syringe without the needle. For children aged less than 2 years, a teaspoonful every 1 to 2 minutes. Older children and adults may take sips directly from the cup. Vomiting usually occurs during the first 2 hours of treatment, especially if child drink quickly. Rarely prevents successful ORT, but most of the fluid is absorbed. After that, vomiting usually stops. If child vomits, wait 5 to 10 minutes and then give ORS solution again, but more slowly. Treatment Plan B: treatment of dehydration within 4 hours. Food is in Plan A, fluid is Plan A, except the amount of ORS 75 ml per kg body weight. If child vomits, wait for 10 minutes, then continue ORS but at slow rate. If child eyelids become puffy, stop ORS and give plain water or breast milk till puffiness is gone. Give ORS as in Plan A. Follow up for reassessment. After 4 hours, reassess the child. No signs of dehydration. Consider the child fully rehydrated. Skin pinch is normal. Thirst has subsided. Urine is passed. Child becomes quiet, no longer irritable and often falls asleep. Child still has signs indicating some dehydration. Continue ORT by repeating treatment Plan B. Start to offer food, milk and other fluids. In treatment Plan A, continue to reassess the child frequently. If signs of severe dehydration, shift to treatment Plan C. Treatment Plan C: treatment of severe dehydration quickly in hospital to avoid death. Give Ringer's lactate solution 100 ml per kg. If not available, use normal saline. Reassess child every 1 to 2 hours. If no improvement, give IV drip more rapidly. Give ORS by mouth 5 ml per kg per hour as soon as patient can drink. Evaluate patient after 6 hours in infants, 3 hours in older patients. Then continue treatment according to appropriate Plan A, B or C. Indications for IV Ringer's lactate therapy: severe dehydration Plan C, failure of oral rehydration, paralytic ileum, unable to drink as in coma. Indications for giving ORS by nasogastric tube: repeated vomiting, refusal of ORS or unable to drink, stool output exceeds ORS input, exhausted mother. Chemotherapy is indicated in infective diarrhea due to Shigella and Vibrio, protozoal diarrhea due to Diarrhoea and Entomoeba histolytica, and any existing systematic bacterial infection. Symptomatic treatment: fever, no antipyretics or RS is valuable. There's interaction between fever and dehydration, cold compresses with light cloths and treatment of any associated systematic infection. Diarrhea. Diarrhea helps elimination of infection. It is self-limited and improved by rehydration. Avoid antidiarrheal, adsorbent, choline, pectin, and anti-motility drugs. Vomiting. It is due to loss of electrolytes and acidosis. Slow intake of ORS improves vomiting. Avoid antiemetics. Abdominal distension due to loss of potassium in stools or ileus.